Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This is the first of a two-part educational series, IL-31 Inhibition for Treatment of Prurigo Nodularis, supported by an educational grant from Galderma. Hosted by expert dermatologist Dr. Shawn Kwatra, professor and chair of dermatology at the University of Maryland School of Medicine. This first episode, examining the gaps and challenges in diagnosing and treating prurigo nodularis, features expert Dr. Sarina Elmariah, a board-certified dermatologist and neuroscientist, and associate professor and dermatology director at the Center for Itch and Neurosensory Disorders at the University of California in San Francisco.
I want to welcome all the listeners to part one of this exciting educational activity. We're going to be examining the gaps and challenges in diagnosing and treating prurigo nodularis. I'm Dr. Shawn Kwatra, and I'm the professor and chair of dermatology, University of Maryland School of Medicine. I'm also joined by an expert in this topic, Dr. Sarina Elmariah. Dr. Elmariah, Sarina, do you want to introduce yourself? Thank you so much for joining us today.
Shawn, it's a real pleasure to be here. You know, I get fired up about prurigo nodularis, so I'm excited to talk with you. I am, as you know, a dermatologist and a neuroscientist. I see patients at the University of California, San Francisco, and I'm the director of our Itch and Neurosensory Center. So again, PN is a topic near and dear to my heart and really happy to be here.
Absolutely. All right, so let's get started. First question, who do we typically see affected by prurigo nodularis? What does this patient population look like? What are your thoughts on that?
So patients with PN, kind of the typical PN patient is going to be somebody in their middle ages, about, in their 50s, 60s, 70s. It's a slightly more predominant in women, a predominance in African Americans, or Black patients, Black and brown patients. But I will say that it really can affect the whole spectrum of patients. There aren't a ton of kids with this, but I do actually see kids with it. One thing that I'm sure we'll touch on at some point is that PN is at this point, pretty, I think, under-recognized and actually not diagnosed as, for example, as easily as something like atopic dermatitis or psoriasis. And because of that, the patients that we see fall into this category, but I do think it affects a broader range of patients for sure.
Absolutely. I love that comment about how it absolutely is more under-recognized than atopic dermatitis, and just got its own diagnostic code in 2015 to actually label prurigo nodularis as a disease. So a lot of these patients before that time were just floating around as dermatitis, not otherwise specified, really not having that label of having a disease. So for me, and I'm sure also for you, it's mind-boggling that we're still having situations where patients are coming to see us. We tell them that they have prurigo nodularis, and they have tears of joy because they finally have a diagnosis. It boggles my mind that this continues to happen. Has it been happening to you too? Do you have like a similar sentiment on that the awareness seems to still be so low?
I mean, absolutely. I think the common perception is that PN is very rare, right? I mean, you even did, and there have been several studies that have looked at this prior to there being a diagnostic code. But since the introduction of its own ICD code, it's still considered very infrequent. And I will say that the numbers are not as common as something like atopic dermatitis, which you'll see several times in just a regular general dermatology practice. But I do think it's underdiagnosed. So, and part of what leads to that is the fact that it can have overlapping features sometimes with other diseases. Patients will be put in as having itch, not just dermatitis NOS, but just chronic itch NOS, right? And before labeling or diagnosing, I think the accurate term is diagnosing with prurigo nodularis, patients will have all these other labels as people try to rule in or rule out so many other things, while just really obscuring the PN diagnosis itself. And so, there's also this unfortunate aspect of this particular disease where even if somebody suspects PN, they don't necessarily get diagnosed properly or even worked up properly, just because people are trying to evaluate other things. And then there's this other, kind of, I always say 800-pound gorilla sitting in the room, is that so many people, because they struggle with PN and how it is so disruptive to their lives, the mental health burden that goes along with this, many people are essentially, put into that category of neurotic excoriations, or excoriation disorder, where people really pin this on there being a psychiatric issue as opposed to being a psychiatric comorbidity to a disease that is so disruptive. And that, I think, also leads to its under recognition and under diagnosis.
Absolutely. I love the way, you said that. And when we did our first initial analysis of number of cases of PN, it looked like it was maybe a rare disease, under a couple 100,000 cases. But every year that we look again, the numbers are going up. So 300,000, probably even higher than that, 400,000. So I think, like you said, the disease is not as common as atopic dermatitis, but I think much more common than any literature report has established. And that is a common journey that patients are underdiagnosed. So I think we've established PN is underrecognized, it's underdiagnosed. But now let's discuss what actually can clinicians do to recognize PN early and accurately. So, Sarina, what are the big clinical findings for you that are indicative of a diagnosis of PN?
Dermatologists around the U.S., you and I included, as well as throughout Europe and really the rest of the world, have gotten together to try to characterize or start to make these, essential diagnostic criteria, if you will, for prurigo nodularis. And it's important. One thing to emphasize is that it's a clinical diagnosis. Okay, so the three kind of hallmark features that we all go back to is that somebody's got to have chronic itch, which means they've been itchy for over 6 weeks, essentially consecutively. Usually in most of these patients, I'm sure, Shawn, you've seen these patients who come in for like years. I mean, even decades at times, where they've suffered with this. But so chronic itch is one. The fact that they have, it's in the name, nodularis. So that they have nodules or some type of skin lesion. And I'm sure we can get into those, to the nuances of that, but they have to have some element of chronic itch plus nodules, and skin lesions. And then they have to have some evidence of skin manipulation or scratching, right? So, some evidence that they're to kind of support their reports of their chronic itch. Those are the three hallmark features, although the disease is far more complex than just those aspects.
Do you do a biopsy regularly or not to make a diagnosis?
I mean, so I don't, right? I think, again, PN, prurigo nodularis, it's a clinical diagnosis, and important things to be, that we'd emphasize is that, I do a biopsy when I'm either trying to rule out another condition, for example, like if somebody I might think has hypertrophic lichen planus, right? Or if I actually think they have more of a solid, kind of perforating disorder, although a lot of people still put that on the spectrum, with PN. But if I'm trying to rule out something else, as opposed to trying to confirm or actually diagnose prurigo nodularis, I think that's a really important part. So I'm curious what you do. I mean, I talk to a lot of providers and they always do a biopsy because they don't want to miss something. And I don't have a problem with that, but I do think it's important we emphasize that, a patient can have prurigo nodularis even if they have other conditions, right? I actually have patients who have, hypertrophic LP, who have dermatomyositis, who have atopic dermatitis, who, that's one of the more common overlapping cutaneous comorbidities. But it still is, it doesn't supplant the fact that they then have PN. How about you? What do you do?
I'm very similar to you. So just look at patients and we can see such a wide variety of manifestations in PN. We can see the classical large nodules, papules, excoriations, all of those things. And I've learned also to go by just a few key features. Itch. Do they itch? Have they itched for, longer than 6 weeks to make it chronic? That's it. And do they have signs of repetitive scratching? They can have many of these different variabilities in how that scratch looks. So, we've done some genetic studies about how certain ethnic and racial groups may have more fibrotic disease, and a lot of that can be also genetically encoded. So don't necessarily go by only how it looks. It can have a lot of different manifestations.
Can I make a point on that?
Yeah, go
sorry,
ahead.
I didn't mean to.
Go ahead.
I think that is such a key point that you've made, because a lot of the patients who I find who don't receive a diagnosis of PN are because they may have one or two nodules, but then they have papules, or then they have, erosions, right? And then they get put into a completely different category of disease when they really have PN. And so I think it's important to recognize that really these patients, even if they have nodules, they may have papules, they may have even sometimes, like deep erosions in terms of just how severe their itch is. They may have plaques, right? These really extensive fibrotic plaques. Sometimes, you'll have patients who just have excoriations with even hyperpigmentation and resolution of other lesions when they're somewhere in their, if they're being like partially modulated or, improved with their medications. But I think it's really important. It behooves us all to be mindful that it can present in different ways in different patients and even in different times. So that's, I think kind of critical, and in different skin types, actually, as you mentioned.
Absolutely. The different manifestations, I can think of many instances, even in the last few weeks with my residents, where we've had exactly what you said, different manifestations, not necessarily only the nodules, but papules, excoriations, other things like that, and being mindful of that. So I think that is definitely key for everybody listening. The other thing is, absolutely agree, you don't need a biopsy. And sometimes I find that a biopsy actually opens Pandora's box to who knows what comes out. So I like to tell a story of a patient that was referred to straight to an oncologist. The oncologist happened to give me a phone call, and they told me, hey, I have this interesting patient. They had biopsies in a few of their spots, and they all came back squamous cells. So we're about to do systemic immunotherapy for them. But, something just didn't fit. So would you mind taking a quick look? So then I looked at the patient, and it was clear PN. There's itch everywhere, these nodules, and the dermatopathologist just read it as a squamous cell carcinoma. I mean, think about it. There's a lot of hyperkeratosis. There's epidermal acanthosis. There's anthosis. There's fibrosis. There's pseudoepitheliomatous hyperplasia. I mean, you could necessarily, put it into that basket. And this poor patient was about to get immunotherapy. So I've seen it many times. You do a biopsy and it comes back in different ways. I mean, depending on how you scratch, how much skin thickening you have, it could come back as all sorts of things. So I'd be the same way, unless it's like something like blistering disorder, like you were alluding to, or like planus or other things like that. Otherwise, I actually like to avoid a biopsy to just get rid of all of that confusion that could come downstream from it.
Yeah, I mean, I think I agree with that. I think that it's important. Again, we are dermatologists. It is absolutely part of our skill set and our toolbox, to be implemented when you really are trying to rule out something. I just like to stress that it does not need to be done to rule in this diagnosis. And, I've had similar patients like you, where they had actually had multiple biopsies. I mean, countless biopsies, because people couldn't, one thing that's very characteristic about this, unfortunately, for this patient population is they go from doctor to doctor to doctor, in between seeing dermatologists, they will see a hematologist, they will see their infectious disease specialist. They get led down all these different really frightening tracks very often. And in between that, a new consultation is being done for another biopsy. So, just be mindful, of that when you're thinking about making PN as a diagnosis. So, I have a question for you, because workup and comorbid, I mean, you've done extensive work over many years trying to identify the comorbidities of this this disorder, right? That there are many. And so again, on this note that people are always trying to find the underlying cause, right? What is PN secondary to, as opposed to recognizing it's a distinct entity in and of itself. So what are the key things you think somebody should actually be evaluating for when they're seeing a PN patient? And then, I'd love for you to make a comment of, do you wait to treat that patient while you're working up these potential associations, or do you kind of jump right in?
Yeah, it's a great question. So
there was a lot there, Shawn. Sorry.
Yeah, something that we spend a lot of time thinking about, because you're absolutely right. Even just a few years ago, everybody says, oh, yeah, PN, let's find what it's secondary to. It has to be secondary to something. I give talks still all the time at conferences, and people are always like, well, what's it secondary to? I don't know if you're studying a disease. So I think the first thing to establish is, yes, this is a disease. It's its own entity in its own right. And yes, there also can be associations with other conditions. And so some of our work has been trying to entangle this and looking at other diseases like atopic dermatitis and psoriasis. Psoriasis is known to have many comorbidities with like cardiometabolic disease, diabetes, and PN's very similar in that regard. PN also has some other comorbidities, chronic kidney disease, HIV, a few other liver disease, a few other things like that. But there's so many patients that have prurigo nodularis and they don't have these other conditions. So I like to say, prurigo nodularis is absolutely its own disease entity. We do a lab workup. And the reason we do that lab workup is our genetic study that we performed for multiple continents showed that there is a polygenic risk score that can predict who develops itch with skin lesions, PN, or without skin lesions, just generalized itch of unknown origin. So that's the analogy. The analogy of PN is with itching overall, not necessarily with atopic dermatitis. And so for itching overall and for PN, you want to see, is there something that, what I like to say, may not be causing the itch, but maybe slightly lowering the threshold for itch to manifest. And so one example of that is type 2 diabetes. So if someone has type 2 diabetes, we all know there's all kinds of nerve damage, neuropathic disease, all of this stuff that could happen from diabetes. We also know it's much more common in PN. So one thing that we surmise is, well, perhaps, if you have elevated blood glucose, and Sarina, you're probably the best person to even comment on this, perhaps if there's elevated blood glucose, perhaps that could alter some of the cutaneous nerves and influence the milieu to make you more likely to have PN. But even though you might influence the milieu, to me, that doesn't change your treatment approach. You're still going to treat with treatments for the disease. So I don't ever wait to treat an underlying condition. I'll also treat that while we treat PN. But I think that myth needs to be worked through. But I'm curious to get your take on that as well.
Yeah, I mean, I couldn't agree more. So when I have a PN patient come to me and I feel pretty confident that PN is the right diagnosis for them, I obviously inform them about that. I inform them of the fact that occasionally PN does arise secondary to what we believe are things that contribute to neuroimmune dysfunction, inflammatory dysfunction in the skin, and even, excessive fibrotic disease, which I know is a track that you're also, very interested in and looking at. But we talk about those factors, and I say we're going to look at associated, potentially associated comorbidities while we're treating you, because the burden of this disease, which I'm sure we'll get into, is really, it's immense, right? It really kind of overshadows a lot of diagnoses and entities that we manage on a day-to-day basis in dermatology. It is so severe, but I try to. I do a basic, CBC, a CMP. I look at their renal and their hepatic function. In older patients where I think, could there be a hematologic malignancy here? We'll do, an SPAP immunofixation, serum-free light chains. I do that part of the workup. I make sure they may not have, if they have risk factors, other infectious etiologies, HIV, even, actually I've had a couple patients now who've had syphilis who ended up, turns out they had like a PN-like manifestation. So there are things that you look for based on the patient's risk factors, for sure, as part of the workup. But like I said, and like you said, it doesn't technically stop me from saying, in addition to doing this, let's actually start to manage your disease, because PN can superimpose itself on other things. So it doesn't have to be secondary to anything, even if it is, right, in some cases. So, yeah, and then one of the other things that I just want to touch on before we even jump into some other aspects is that I do think it's important, as you're starting to see more of these patients. I mean, I have patients self-diagnosing and coming to me because they feel like they've been failed by the medical system. They're coming to me now saying, I think I might have PN, like they heard a podcast or they saw something, and again, I think the numbers of PN in terms of prevalence are probably going to increase just based on the fact that the word is getting out more. However, patients will come to me, and part of assessing the patient is not just assessing, they're like, they're just giving them the diagnosis. It's assessing how severe it is, right? So we try to establish how severe are they being affected at that first visit, so we can follow it over time as they're on, various therapies. And so there are a couple ways to do that. I personally, and I'm curious to hear what you do, I personally always try to get a numeric rating score for their itch, just like you do for pain. I do it for itch, the 1 to 10, simple, takes like seconds. Often they're, you can have your MA or somebody else, whoever's helping you room the patient, do that as well. The other thing that I always do is try to get a Gestalt assessment, right, of just the extent of the lesions, like what's the distribution and about how many, so I can assess the severity. There are scores. There's, the Prurigo activity and severity score. There are quantitative ways of checking these. I find those a little bit, for me, less practical in a quick visit. So I just do NRS and the Gestalt kind of quantitative, semi-quantitative, I guess, approach. And then I also do what I call the Sarina's quick qual, which is, I basically say, is this waking you up at night? Is it keeping you up at night? How's your sleep? And then is it preventing you from doing whatever it is that you need to do in your life, right? Whether it's working or school or what have you. And that's my quick sense of how to figure out how much this is really disturbing, my patients. And I'm curious, like, what you do, because this is an important point we should probably drive home with people. You need to follow something, kind of objective when you're trying to figure out how people are doing.
That's a great point. No, I like your approach. Mine is absolutely very similar. I think we have very similar mindset to PN. Always asking about the itch with the numeric rating scale. I like to ask, what's your worst itch in the last 24 hours, any moment? So get that number, just ballpark. 7 or higher really piques my interest as being very severe. And that alludes to sleep, a question next with sleep, like you asked. Just how are you sleeping? Open-ended, very, very quick open-ended question. And then the assessment for me is definitely clustered around the number of skin lesions. And I like to just document it as an investigator global assessment. So 0, 0, 1 is less than 6, 2 is 6 to 20, 3 is 20 to 100, and then 4 is over 100. And that can help also with the payers getting certain drugs approved. And those are just I think the big ones, just you can kind of get a Gestalt. Someone comes in with lesions all over their body, their itch is like a 10, and they have all these spots, it's pretty severe. The other thing I'd add is the itch is important here because although most patients are itchy in the nodules, there are majority of patients are itchy both in the nodules and in the normal appearing skin. And there absolutely is circulating inflammatory mediators in the blood, like gamma delta T cells, NK T cells, other immune pathogenic mediators. So there are situations where, people may have very incredible itch, not as impressive skin lesions, but they do have raging inflammation that's out of control. So just understanding that there are opportunities for mismatches there. And so I always like to use itch as that clinical bedside biomarker of inflammation and disease severity and sleep. And we know it correlates with everything, DLQI, the quality of life, all those empowerments.
Yeah, I mean, it's funny that you say that. So I like one of my earliest PN patients, when I had just become an attending at the time or a faculty member at Mass General Hospital in Boston, I had this patient who had come in, and she clearly had PN, right? She was, on hemodialysis, clearly had various risk factors that may have predisposed her to PN, but definitely had pretty severe PN, hundreds of nodules. She had the classic butterfly sign that we often talk about, on the mid back, where you can't scratch. And I had always learned that you only had PN. PN only affected you in the areas, right, where you where you scratched. And that led to this idea of the butterfly, or the observation of the butterfly sign. But I remember asking her that, I said, well, do you not itch on the middle of your back? And she goes, that's the part that drives me even more insane, because I can't alleviate it. I always feel itchy there. But she had tried to take rakes. She had done, like an actual rake. People have used knives or things like that to get to those areas. So people may not have the butterfly sign because they're creative, right? But the point I'm trying to make is that they're still itchy in those areas. It suggests two things, right? There is some systemic contribution, no doubt, right? The other important part of it is that to develop the nodules, and I know we're talking a little bit more pathophysiology here, and that fibrotic, kind of process, part of that does come from the mechanical trauma scratching. So scratching does actually play a role in the pathogenesis of this disease. But the itch may actually, to some extent, be, a separate underlying and really unifying symptom across, a patient's whole body surface area. And certainly the kind of, from the neck down, we see that a lot. Occasionally patients will get it on their scalp and their face too, but for the most part, I think it's, extremities, as upper back, things like that.
Man, that's a great story because it dispels the myth, the itching in the butterfly area.
Yeah.
I really enjoyed that. We talked about burden, but what do you think contributes the most to the disease burden? What are the most important complaints of practice? Obviously itch, we can start there, but what else are the
itch, certainly if you ask a patient, right, itch is always the first thing they mention. That's what they're coming to you for. And that's been documented now across multiple studies in Europe. Yes, that itch is usually the first and most profound and burdensome symptom of PN. But there are actually so many other features of this disease and issues with this disorder that really burden patients. The nodules themselves, right, are burdensome. They actually lead to, I think, a lot of the quality of life issues that arise with this, independent, of the itch, in terms of the fact that the nodules, the discoloration, even the marks on one's skin when when the nodule has resolved, can be really disruptive to a patient's quality of life. So many of my patients, and I know this is true of yours, I've even talked to some of your patients, where they have to change how they dress, right? They don't go out anymore, not just because of the itching, but the fact that they have all these marks and ulcerations, sometimes they're worried about infection, or they have to just cover themselves. They can't wear their shorts and their t-shirts to a barbecue, and that's when they're even feeling like being socially engaged. So these are all concerns that these patients, have. We already mentioned sleep. Sleep is a huge thing early on in this disease. And I say, I'm talking about patients who have had the benefit, right, of being on a therapy that has been able to actually help reduce their itch. But one of the first things outside of just the itch going, kind of being controlled, that patients talk about is, I can sleep again. Right? Like I can actually focus at work. Like I can actually focus on a conversation with my kids. It's really, sleep, the impact, disruption to sleep, the improvement in sleep are things that patients always, focus on. And then there are just so many other kind of emotional aspects that go into this disease, again, which may have led to people thinking this is a neurotic, or psychiatric issue, which it's not, just because of that associated burden.
I totally agree. Unstoppable itch, can't sleep, anxiety, depression, can't focus, impaired work productivity, and the disfiguring lesions so it impairs your social life. Man, it's terrible. And when we looked at overall quality of life, it's like having a stroke, the effect that it has on your overall life. And still, when we tell people this is a severe itch disorder, I feel like there's not enough recognition of just how bad this disease is. This is really one of the diseases that can ravage your whole quality of life more than any other disease, I think.
Yeah, actually, in your study, it was so profound to me when you did that, those kind of quality of life and utility score analyses that essentially showed somebody suffers more from PN than they do from being on hemodialysis, even more than a stroke. You mentioned stroke, even more than a stroke. There were very few things that people could deal with, more easily or less easily than PN. Like they just basically didn't want COPD. They didn't want to be able not breathe. And so that tells you inherently how profound the impact, that this condition has on people's lives. Again, to me, reinforcing the idea we need to recognize this disease and we need to treat the disease.
Absolutely. And even more so, it's so important the therapies we select because of those comorbidities, diabetes. Like you said, some patients have kidney disease, liver disease, a lot of these things we have to be careful with therapeutics. So let's briefly give a broad overview of current recommendations and practices for treating prurigo nodularis patients. So let's start with this. How often are you able to manage patients with PN patients with topical or systemic therapies?
Well, I'd say with topicals, if somebody has localized disease or if they have disease that for whatever reason, whether because of some other systemic therapy or because of some other change in their overall health status, where their disease is very localized or very just limited in severity. Again, not a high nodule count. They're not disrupted quite at night. So like those mild to moderate, like early moderate patients that may be out there with PN, I would say topical or kind of lesion-directed therapies, right? Like even, intralesional Kenalog or sometimes cryotherapy. Like I find that those can be useful and they can be useful adjunctively. In terms of the average PN patient, that one, as you said, who's moderate to severe, has that, NRS itch score of 7 or above, like really struggling, topical just doesn't cut it. And by the time they get to me, they've already exhausted topicals and usually even 1 or 2 systemic. So I think, for me, systemic therapy is almost always warranted in many of these patients. And that may be, by the way, for reasons that you pointed out earlier, right? That there's a systemic inflammatory and neuroinflammatory underpinning to this disease. So we have to be very mindful of that. It's funny. I get sent patients who may have a diagnosis of PN or something else, and they're kind of considered refractory. And to me, I guess they're refractory to topical therapy, but that is essentially the nature of PN, right?
Absolutely. That's a really great point. We see it too much. Patients come in, they're just on triamcinolone, other topical steroids, months and months are going on, and these patients are just suffering. It needs to stop. So I agree. Maybe I'm biased, but almost every single PN patient I see needs to be on a systemic therapy immediately. Definitely happy to do adjunctive topical steroids, adjunctive intralesional steroids, other topicals. Fine, that's okay. But yeah, I think we need to really be hitting patients with systemic therapies early in most cases. So I totally agree with you on that. So what is your kind of gamut of therapies? I'll tell you for me. So we have, I like phototherapy a lot. It's slow. So if I do that, I'll oftentimes have something else going on. Before we had any of these new amazing like targeted agents, I'd probably usually go with methotrexate, maybe adjunctive gabapentin. But now we're really living in a great time with these new therapeutics, dupilumab, nemolizumab, which have been game changers. But those are kind of some of the top level things that, with the evolution of time, some agents that have floated around as like most common. But do you have any thoughts on that? Like broad strokes, thoughts on therapy? Say somebody is more of a systemic therapy patient. What are the types of things? How's that changed over time, et cetera?
Yeah, I think similar to you, I tend to be aggressive with managing these patients when I look at the disruption to their quality of life. And even before the bulk of the pathophysiologic studies that you and other of our colleagues have been doing, I think most of us have recognized that there's got to be some neural underpinning to this and neural dysfunction, going, back even early to data from like Sonia Stander and others that have looked at this disease. But even before having a really solid understanding of it, I would always have patients on a neuromodulator, whether it was a gabapentinoid, whether it was like a tricyclic antidepressant or something that's been used for itch or pain before, right? So I would have patients on that. I'd have them actually on high doses of it, and recognizing that there is an inflammatory component to this, I'd always have patients on some type of systemic immunomodulator or immunosuppressive agent. For some patients, I'd put them on cyclosporin. For some patients, I would put them on Celsep. That was actually mycophenolate was the one that I really liked, or methotrexate. But again, you have to take into account these are older patients. They have multiple comorbidities. You need to actually be thinking about that. Certainly, in this dawn now of emphasis and interest in prurigo nodularis, in part because of like your work and others, I think with drugs that are now actually FDA approved, that have been vetted in clinical trials, all those drugs before, there were very few clinical trials, and even those were not particularly compelling. Now we actually have FDA approved agents in dupilumab and nemolizumab, but these have been studied in a large number of patients, and they're safe. They're safe agents. So it makes it a little bit easier, I think, even when we're talking about just your gen derm clinic, right? You see somebody, you suspect they have PN, you're ordering the tests. It's not hard to say, hey, look, this is a drug that's actually been studied in your disease. It's been shown to have benefit. In some cases, relatively rapid itch within some, with nemolizumab within days to weeks, within, even with dupilumab, even within a month, these patients can get so much better. And just knowing, you mentioned this, just having a diagnosis, let alone saying, hey, there are options for you that have now been studied, is really an incredible experience. So that's been my evolution. I mean, I, for one, actually still keep people on their neuromodulators, or if they're on antidepressants because of this, I'll keep them on those agents initially. Once patients get better, I'll start to pull away, or certainly if they have any side effects, I will take, some of those off the table. But I think, getting patients to the point where they are finally feeling better is really, in all ways, right, is the goal here, right? They got to get their itch first and foremost under control, and then I always say good things will follow.
Yeah, no, absolutely. That resonates with me too, and we've all had these patients that oftentimes need multimodal therapy, speed of onset. These are all important things. So now that we are entering a new chapter, and we've recently seen the FDA approval of nemolizumab, an interleukin IL-31 inhibitor for the treatment of patients with prurigo nodularis, what in your mind makes nemolizumab different from other standard of care therapies, even the other approved therapy, dupilumab? Do you have any high-level thoughts, impressions on nemolizumab and IL-31 inhibition in PN?
Well, I think the important thing here is actually to recognize that, as opposed to in the past using agents, like I said, gabapentinoids, neuromodulators, these chronic, other broader immunosuppressive agents, both dupilumab and nemolizumab are actually going after something that is really central to the evolution of prurigo nodularis, and that is, this kind of type 2 dysregulation, right, and immune dysregulation that's fueling part of the neural activation, and then the neural, kind of feed forward aspects of stimulating part of the immune response. So that cycle, right? And of course, even the kind of the itch and the scratch that go together that lead to these PN lesions. Nemolizumab also, there's evolving data that suggests that we may be actually also intervening with the fibrosis. So when you are down regulating type 2, inflammation, that you're actually starting to tweak that fibrotic cascade. And so the idea here is that these agents, nemolizumab, in particular, is really starting to go after really the crux and the part of the initiating and certainly perpetuating factors, right? And I would say that is true both of dupilumab and nemolizumab, whereas all before, everything was much more, I think they were just general and they were not as specific or as targeted to the pathophysiology at play. So, and that's why we'll see these profound effects. In the Olympia trials, itch improved within days with nemolizumab. I think you ran one of those trials. So you actually, you saw it. These are people who failed cyclosporin, right? These are people who failed the highest doses of pregabalin. I mean, I have people with neuropathic pain who've been on pregabalin where they got some benefit, right, from their PN, but unbelievable how you could then go on a drug that would just really take that itch, the severity of that itch for sure, completely out of the equation, or at least, over that very quick window, reduce their itch by even 4 points, right, on an NRS or peak, pruritus scale. So I think that's, it's given me a lot of hope for managing this disorder and bringing people back to really to themselves.
Yeah, no, absolutely. First off, we are just all so lucky that there are trials going on. There are new therapeutics that have recently been approved or are becoming approved. So it's really excellent. So let's start with dupilumab. Dupilumab, obviously IL-4 and IL-13, they sensitize the peripheral neurons. They're involved in itch biology. Of course, they're involved in immune trafficking. So a big advance in PN. IL-31, just in general, to me, is such an interesting cytokine. From the mouse studies, it seems like there's this dose-dependent increase in itch no matter where you inject. It seems like almost a neurotransmitter in itch. So, Sarina, you're an expert in this neuroinflammation, neurobiology. What's your high-level scientific view of just IL-31 to start, too?
Yeah, well, I mean, IL-31's been called the itch cytokine, right? I mean, I'm a firm believer that there are other pruritogens, right? It's not all IL-31, and it's important to recognize that type 2 diseases have an increase, right? Have an increased expression of things that can either directly act as a pruritogen, right? Or can act as a modulator of pruritic, activity, if you will, and that sensory signaling. But IL-31, if you put IL-31 on nerves in a dish, they are actually going to fire, their action potentials. And in an animal model, you inject it and it actually increases scratching, right? So we call this, relatively acutely over a very short period of time. So we call it a pruritogen. There are, so by blocking IL-31, with a monoclonal antibody antagonist, you are able to block part of that itch cascade, right? I do want to express the importance of not just the acute itch, which is very important to the patient, right? How they feel, being able to block that itch, that constant itch signal that's out there. But even when you decrease the activity of nerves. This is true kind of for itch and for pain, various sensations. You also kind of stabilize that neural activity in response to other pruritogens. And we do see that actually with nemolizumab and with dupilumab. So these are, and we've seen that kind of in studies that are not, in animals, in nerves in a dish, but we see it also in patients. Like whether you kind of put the slow brakes or the acute brakes, like you're slamming down on the brakes, you're also making those nerves less susceptible to being triggered and sending that itch signal. And that's part of the healing process. It's actually very important. And I think as you see even emerging therapies down the line where they're kind of throwing their hat into the ring, for improvement, in itch, chronic itch, but certainly also if specifically prurigo nodularis, you're going to see that mast cells are playing a role, that there are going to be other pruritogens that also, and signaling cascades that are critical, but that these, even if you're just blocking IL-31, right, you are still you're decreasing the itch from IL-31, but you're also decreasing the itch from, or the susceptibility to itch of these nerves. Sorry, I waxed long on that, but it's a point I think is really important that we need to make to, each other, providers, and to our patient, right? That it's an evolving, really complex process. I mean, PN is one of the most fascinating disorders, that in my career I've really I've had the pleasure of studying and working with, patients who have suffering from it. So.
Absolutely. I love the way that you described it. And I agree. There's a complex biology going on here, and we can tamp down on this itch scratch cycle at a variety of time points. So totally agree with you. There's a place for all of these therapies. Dupilumab also targets, has approvals for a lot of other comorbidities, even emerging evidence COPD. Nemolizumab here, I think in PN also is very much so tailored to the biology of PN. PN, yeah. the itch that rashes, right? Do you stop the itch first? Does it help with the rash downstream? And that's what the studies all show. That you help with the itch fast within 48 hours, 48 hours. It works quickly. And then in the long-term extension study also, that I presented at last year's American Academy of Dermatology meeting, we found that over 70% of patients had almost no nodules at a year. So this does mirror the biology of the disease. You tamp down on itch fast, the lesions fade.
Well, a couple of points I'd want to make on that is that there may be a role, right? I mean, there's ongoing investigation of this, but there's a role for the impact on itch, for the impact on, of eliciting, certainly that cascade, but also on the inflammatory components of it as well, right? Yeah. As the fibrotic aspects of the disease. And so I agree with you. That was, kind of my point from before is that, this is really targeted. And when we think about the itch that rashes, that's classically ascribed to atopic dermatitis. And even though, again, emphasizing these are distinct diseases that may have some overlap, even clinically as well as pathophysiologically, the idea that you have these cytokines, these type 2 cytokines that bring together this, kind of coordination of itch with skin changes and inflammatory changes, as well as even structural changes, right? Like the fibrosis is, I think, going to be really revolutionary to this disease, but also to recognize that nemolizumab and agents that like dupilumab that address this type 2 dysfunction are likely going to be useful even across other itchy conditions because of that, and that obviously will be supported. It is supported by the trials for nemolizumab, even in AD. We're talking about PN, but mind you, it is going after part of the crux of this issue.
Absolutely. I think that's really important issues that you bring up. So yeah, very exciting time in general. And thank you, Sarina, for your time and input into this really timely and relevant discussion. Do you have any last key takeaways for our audience?
Well, first of all, thanks so much, Shawn, for hosting this and taking the time to talk about this condition, with me. I would say key takeaways for me, do not delay a diagnosis of PN. If you suspect it's PN, obviously initiate a workup that you feel is sufficient, but it is a clinical diagnosis. And then given the severity that, in terms of quality of life and disruption that something like PN poses to your patients, don't hesitate to really jump in and start to manage them. They go, diagnosis and management go hand in hand. And with these newer agents that I know you're going to explore this in your second in a second podcast, but with these newer agents that are so safe, certainly think about implementing early and getting patients on that right, kind of the right path, because it will just make a world of difference for them.
Awesome. Well, thank you again, Sarina, for those incredible insights. We had a great time chatting together, as always.
As always.
So listeners can all stay tuned for part 2 of this educational program, where we'll dive deeper into the mechanism of action of IL-31 inhibitor therapies for prurigo nodularis, as well as the clinical safety and efficacy data, and some practical considerations for prescribing and patient selection. Thank you.
Stay tuned for our next episode on IL-31 inhibition for treatment of prurigo nodularis. Thank you.